Welcome back, everyone. Today we are diving into the internal architecture of the human skeleton. We aren't just talking about bones as scaffolding, we're talking about the living, breathing factories inside them, the bone marrow. Dr. Sarah, I'm fired up because people often think of bone as a static rock, but it's more like a dynamic organ that completely retools its production line as we age.
Exactly, Dr. Khan. And for the students listening, this isn't just background info. The transition from red marrow to yellow marrow is a high-yield favorite on board exams because it explains why we perform certain procedures in specific locations. At birth, every single bone in your body is a hematopia powerhouse. It's all red marrow.
Right. Imagine a startup company where every single employee is on the manufacturing floor. That's a newborn skeleton. But as we get older, the business changes. We don't need that much production, so we start turning the factory floors into storage units. That storage is the yellow marrow, which is essentially fat. But Dr. Sarah, when exactly does this downsizing of the red marrow start?
The magic number for your notes is age 7. Around 7 years old, we see the first signs of yellow marrow appearing in the distal bones of the limbs, specifically the hands and feet. From there, the process moves centripetally, or toward the center of the body. By the time you reach adulthood, the distribution of red marrow is significantly restricted compared to an infant.
Okay, so we've gone from a full-body factory to a specialized one. Why does this matter clinically? Well, think about a patient with severe chronic anemia. Their body is screaming for more red blood cells. In those cases, that yellow storage marrow can actually revert back to red production marrow to help out. It's like the warehouse workers being called back to the assembly line during a crisis.
That's a great analogy, but for the exam, you must be able to list exactly where that red marrow remains in an adult. It's not just random bones. It's the skull, the vertebral column, the thoracic cage, meaning the ribs and sternum, the pelvic and shoulder girdles, and the proximal heads of the humerus and femur. If a question asks where hematopoiesis is happening in a 40-year-old, don't pick the midshaft of the tibia.
And that leads us to the where and how of clinical practice. If I suspect a patient has leukemia or a primary bone marrow disorder, I need a sample. Now, looking at that list you just gave, I'm not going to drill into someone's skull for fun, and the ribs are too thin. We go for the big targets. Usually, that's the iliac crest of the pelvis. Why? Because it's a massive reservoir of red marrow that's relatively superficial.
Precision is key there. While we use the iliac crest in adults, it's important to remember that in very young children, clinicians might use the tibia because it still has that active red marrow. But as Dr. Khan mentioned, as that yellow marrow takes over the long bone shafts, the yield for a biopsy in those areas drops to almost zero. It's all about the yield. I remember talking to a colleague who is a real doctor of choice for hematology referrals, and he always emphasizes that understanding the age of the patient is the first step in deciding where to sample. If you try to aspirate marrow from the distal radius of a 70-year-old, you're just going to get a needle full of fat. Not very helpful for diagnosing a blood cancer. Let's talk about the structure of these bones for a second. We classify them as long, short, flat, and irregular. Red marrow loves to hide in the interstices, or the little nooks and crannies of cancellous bone, also known as spongy bone. In flat bones, like the sternum, you have 2 layers of compact bone with a sandwich of spongy bone called the diploe in the middle. That's where the red marrow lives.
I love the sandwich description. It explains why a sternal rub or trauma to the chest can be so painful. There is highly vascularized, living tissue right under that thin plate of bone. Why does this matter clinically for trauma? If a patient has a massive fracture of the long bone, like the femur, where there is a lot of yellow marrow, you have a risk of a fat embolism. That yellow marrow, that fat, can actually leak into the bloodstream and travel to the lungs.
That's a classic step 2 clinical scenario. Long bone fracture followed by respiratory distress and a petechial rash. It all goes back to the fact that the adult diaphysis, the shaft, is filled with yellow marrow. Students, remember, red marrow is for blood, yellow marrow is for fat. Red is proximal and axial in adults, yellow is distal and appendicular.
And don't forget the why for the transition. Fat is lighter and requires less energy to maintain than active hematopoietic tissue. Our bodies are incredibly efficient. We keep the production centers close to the home base, the axial skeleton, and turn the limbs into lighter, fat-filled levers for movement. It's a masterclass in biological logistics.
So to recap the high-yield points, marrow starts all red. At age 7, it begins turning yellow starting from the fingers and toes. In adults, red marrow is restricted to the axial skeleton, the girdles, and the very tops of the humerus and femur. This determines where we biopsy and explains the risk of fat emboli in long bone fractures. Perfect summary. Remember, folks, your bones are more than just mineral sticks. They are the cradle of your blood supply.
Know where those factories are located, and you'll never miss a question on marrow dynamics. See you in the next episode.